Hello everyone, this is the respiratory most important points and notes to solve the MCQs, and these are exclusively made from the John Murtagh and the Kaplan, and some of the features are covered from the RACGP. To start with the respiratory portion, the most important thing is you should have the concept of the spirometry. You should have the concept of some important respiratory volumes and capacities. So this picture is very important. You can take the screenshot of this picture as well. You can find on the Google as well. The most important thing is that the normal inspiration or expiration, the breathing pattern you can see that the most normal breathing you are doing on the regular basis is your tidal volume. This is the normal volume in the normal circumstances. This is the tidal volume. When you forcefully inspire the oxygen beyond the normal volume, that is called inspiratory reserve volume. Inspiratory reserve volume. The collection of the inspiratory reserve volume and your tidal volume and your expiratory reserve volume, which is your forceful expiration, that is called inspiratory capacity. Inspiratory capacity is basically the maximal capacity a person can inhale, then maximally it can exhale. That is called the inspiratory capacity. This was your tidal volume about the quiet breathing. Then maximum inspiration was inspiratory reserve volume. Maximal expiration was expiratory reserve volume. The collection of inspiratory reserve, tidal volume and expiratory reserve volume is your inspiratory capacity. Despite the maximal inspiration or despite maximal expiration, there is a volume in that is remains in the lung and that is not exhaled from the lung fully. That is called residual volume. This volume remains in your lung in the normal circumstances. If we collectively add this expiratory reserve volume and residual volume, that is called your functional residual capacity, FRC. So, if collectively known as inspiratory capacity and functional residual capacity is collectively known as total lung capacity, or it is a collection of all the volumes of your lung, which is inspiratory reserve volume, your tidal volume, your expiratory reserve volume, and your residual volume. So, the collection of all these is known as your total lung capacity. So, this was the major concept of all the respiratory volumes. Why we are discussing it? Because spirometry is very important. Spirometry or FEV1 is the best investigation of your asthma diagnosis or asthma management. Now, straightforward, we move toward the obstructive versus restrictive lung diseases. Some of the diseases are obstructed, like air is trapped into the lungs, and some of the restricted, that lung is not able to expand fully. Obstructive lung diseases can be remembered as a mnemonic ABC, which is asthma, bronchiectasis, COPD, cystic fibrosis, and bronchiolitis. So these are the obstructive lung diseases. On the other hand, you have some restrictive lung diseases, which can be divided into your parenchymal diseases and into your non-parenchymal diseases. Parenchymal diseases mostly you are concerned with are sarcoidosis, pneumoconiosis, fibrosis, idiopathic pulmonary fibrosis, and interstitial lung disease. You can remember as 3 or 4 diseases are obstructive, rest of all the diseases are your restrictive lung diseases. On spirometry, how can you differentiate between the obstructive and restrictive lung diseases? In obstructive lung diseases, because air is trapped, you are unable to properly exhale the air, so your residual volume is going to be increased. So is the total lung capacity. So there is increase in the total lung capacity, there is increase in the residual volume, and the ratio of FEV1 to FVC is going to be decreased. So a decreased ratio is indicative of obstructive lung disease, and increased ratio is indicative of your restrictive lung disease. FEV1 to FVC ratio is increase in the case of restrictive lung disease, and it is decrease in the case of obstructive lung disease. So this was the important thing. Now starting with the asthma points, there are some important points for the diagnosis of asthma. If the question is asked about the definitive investigation, then spirometry or FEV1. This is the gold standard. This is the definitive investigation for your asthma. If the question is about the emergency diagnostic investigation, so in emergency situation, most of the time spirometry is not performed. So in that case, it is the most important investigation or management. Both are reversibility with the bronchodilator testing. Many a times a patient lands into the emergency and he is severely short of breath, and you gave just salbutamol inhaler, and the patient oxygen saturation improves and the symptoms improve. So this is also indicative for the asthma. Otherwise, between the attacks, there is not much bronchodilatory challenge. So in that cases, between the attack, methacholine challenge test can be used. Methacholine challenge, you give methacholine. There is a reversibility when a methacholine challenge test is done. And the for treatment response, the most important investigation is PEF. So these are some points, straightforward points for the MCQs of asthma. Then we talk about the risk factor for the asthma. Risk factor of asthma are also important. This can be remembered as A, B, C, D, E, F, G, H, I. So basically, a straightforward alphabetical order you can remember as allergens, pollens, animal dander, dust mite, and mold. B for bronchial infection, C for cold air and exercise, D for aspirin, NSAIDs, and beta blocker. These drugs are important as a whole. See, these can be remembered as mnemonic ban for beta blocker, aspirin, and NSAIDs. E denote for emotions and psychological problem like stress or laughter. F for food. Some food are particularly prone the patient towards the asthma. These are seafood, nuts, and monosodium glutamate. G for GERD. This is also very important when you're taking the or managing the patient of asthma. Then H for hormones, that is pregnancy and menstruation. I for irritant in the form of smoke, perfumes, and smells. And J for specific job in the form of wood dust, floor dust, isocyanates, and animals. So these are some triggers towards the asthma disease, and you should be aware of that. Then in the management of asthma, there should be a concept of the nebulizers and inhalers and spacers. These are three different things. Inhalers are used on the home basis. These are the portable devices, and this picture is shown in this very particular inhaler. They can be available in the different names under the market, and they can be short acting and long acting, while the nebulizers are this big device. And the benefit of nebulizer is that the medicine is delivered in the form of fine liquid mist. So a greater availability of the medicine is with the nebulizer. Nebulizer provide better relief and breathing relief more quickly and completely than inhaler, since the patient inhales the medication as the mist over the course of 20 minutes instead of doing a few long breaths. So a nebulizer is definitely important in the management of asthma. But when we talk about the nebulizer versus spacer, there is a level A evidence that the spacer is equally effective or even in some situations better than the nebulizers. The spacer is generally recommended over nebulizer for treating asthma symptom, and it is also cheaper and easier to use. So this is very important that in MCQ what he is asking about the nebulizer, spacer, or inhaler. Spacer can be used along with inhaler. Nebulizer is used alone. So with inhaler, with spacer, the inhaler efficacy is more good, and the medicine is distributed deeply into the lungs. So this is an important thing that with spacer, the inhaler can be better used. Then we're talking about the treatment of asthma. This is also an important MCQ point, that if the patient is developing hypercapnia, this is a straightforward indication for the mechanical ventilation in the asthmatic patients. For the treatment of asthma, first of all, you should categorize asthma into the mild, moderate, severe. You all know about it. The treatment of asthma depend upon the basic treatment is, you can remember it as O shit. O for oxygen, as for salbutamol, which is SABA beta 2 agonist, then hydrocortisone, ipratropium bromide, and theophylline. These are the list of drugs that are used in the asthma management, but these are not line wise management or the priority based. This is basically somewhat the priority based list of medication that can be used. I like lazy Saturdays. I for inhaled corticosteroid, we use inhaled corticosteroid first, then leukotriene modifier, then LABA, and SOS basis SABA, or the symptomatic control we use SABA. So this is an important picture or important mnemonic to use the categorical management of the asthma. Or when we use prophylaxis, or there is basically two concepts. One is the preventer medications and one is the reliever medications. So you can use this line, I am preventer and the SABA is reliever. So I is for ICS, inhaled corticosteroid. Inhaled corticosteroid act as the preventer drug, while SABA is basically your SABA, salbutamol, or short acting beta 2 agonist. These are reliever drugs. So this line can be remembered to remember the preventer and reliever drugs. And for the prophylaxis, when we are using ICS, there is another preventer drug which is sodium chromoglycate. If patient is less than 5 years of age, roughly you can use sodium chromoglycate, or if the patient is more than 5 years of age, you can use ICS. In the young patients, ICS side effects are more, so sodium chromoglycate are more preferred. There is another concept that uh, you can use inhalers, spacers, and nebulizers, in not in all age groups. Here you can see the MDI, meter dose inhaler. Inhalers alone can be used over 8 years, because younger patients are not able to use the inhaler properly, so inhaler alone are recommended over 8 years. But yes, with spacer they can be used under 2 to 4 years. With spacer 2 to 4 years can be used, but with face mask under 2 years can be used. So face mask is a better option, either with nebulizer, either with spacers. Under 2 years you can use the face mask combination to treat the asthma patient. Then these are the some symptoms related to the severity of asthma. Severity of asthma can be in the form of, if the patient is peak expiratory flow is very low, 33 to 50% of patient is developing tachycardia, tachypnea, or unable to complete the sentence, then it is indicating the severe asthma. So severe asthma we have already discussed. If the patient is developing hypercapnia, this is a straightforward indication towards the mechanical ventilation. So these are some points for the severe asthma. Here asthma is wind up, and then we move towards the COPD. COPD and asthma both are obstructive lung diseases. The main difference is their management and the age of onset. Most of the time COPD is older patient greater than 45 years, because these are smokers, and smokers take time towards the COPD development. Then among the symptoms, the asthma mostly present with the chest tightness and wheeze, but the COPD mostly present with the cough. So there is a ton of sputum coming from the COPD patients, mostly from the early morning. There is a decreased breath sound, there is a hyperresonance, hypoxemia, cyanosis, and barrel chest. Barrel chest is very important. Most of the time it is mentioned in the scenario. And again, the FEV1 to FVC ratio is decreased less than 70%. And the treatment, you can remember all the C's for the COPD. COPD presents with a chronic cough, and treatment is anticholinergics. Anticholinergics, C for cholinergics. Then chest is barrel shaped, and cessation of smoking is the most important thing for the management of COPD. Many a times the option is mentioning all the treatment options in the form of drugs, and there is also the cessation of smoking, and you have to choose a cessation of smoking. That is the topmost priority for the COPD management. Then another disease, which is bronchiectasis. Bronchiectasis is basically chronic inflammation, which is a permanent dilatation of bronchi and bronchiole in the form of destruction of the airways. And it can be primary ciliary dyskinesia, it can be cystic fibrosis. These are all the causes of the bronchiectasis. Mainly, bronchiectasis present with the long-term basis. It can present with a digital clubbing, and the treatment option, we have to diagnose the patient on the basis of chest X-ray and CT scan and lab sputum culture. So these are three important investigations, and treatment is against the bronchodilator and the antibiotics. In the bronchiectasis management, the antibiotics are very important, and so is the chest physiotherapy. Postural drainage is very important. Next, we are talking about the lung cancer. Lung cancer, there are straightforward some points towards the MCQs, that the most important, most common lung cancer is a small cell lung cancer, which is either squamous cell carcinoma or the adenocarcinoma. If he is asking about the non-smoker, the most important lung cancer is the adenocarcinoma. If asking about the smokers, the most common cancer is squamous cell lung carcinoma. But if you ask about the most dangerous cancer, then it is small lung cancer. Some of the cancer are central, and some of the cancer are peripheral. These can be remembered by C's. Central cancer is by the word S. You can remember your small cell lung cancer and your squamous cell lung cancer. These both are your central cancer, and the adenocarcinoma is your peripheral cancer. So it is easy to remember as such. Then comes these are paraneoplastic syndrome, which are associated with the lung cancer, like small cell lung cancer is associated with ectopic Cushing syndrome in the form of moon-like faces, ACTH production, SIADH in the form of increased ADH production, and Lambert-Eaton syndrome. Adenocarcinoma is associated with your verrucous endocarditis. This is not very important. Squamous cell carcinoma is associated with the parathyroid related hypercalcemia, and non-small cell lung cancer is associated with the hypertrophic pulmonary osteoarthropathy. So these are some MCQ points. Then small cell lung cancer is also known as odd cell carcinoma. Odd cell carcinoma is highly malignant. We have already discussed that the most dangerous cancer is the small cell lung cancer. It is the most common cancer causing superior vena cava obstruction. This is a very important symptom you have to remember. Metastasis occur in the brain and associated with smoking, more common in males, associated with SIADH and Cushing, and treated with the chemotherapy, not surgically. This we have already discussed that the small and squamous both are centrally and both are smoking associated, while your adenocarcinoma are peripherally, and non-smoker most commonly are represented with adenocarcinoma. Then another important topic is asbestosis. Asbestosis mostly present with asbestos exposure related. It can present as asbestosis, mesothelioma, or lung cancer. Among three diseases, the most common is the bronchogenic lung cancer. It presents as the point lesion on the X-ray, and the mesothelioma that can be remembered as 3 or 4 P's in the form of pleural thickening, pleural effusion, and the pleural biopsy by thoracoscopy guiding pleural biopsy is the most common. This is the potential MCQ mentioned in the Amidex also. And if he is giving the history of weight loss and these 3 P's are mentioned, then it is straightforward mesothelioma. If we're talking about asbestosis, the CT scan finding is ground glass appearance. Next topic is sarcoidosis. Sarcoidosis is basically your restrictive lung disease. As for sarcoidosis, as for steroids. So treatment of sarcoidosis is steroids. Sarcoidosis can be remembered by the mnemonic sarcoids itself, which is it presents as Schaumann and asteroid bodies. There is raised ACE levels, raised calcium. In the ocular finding, you will find uveitis. There is interstitial fibrosis, which is restrictive lung disease. There is dry eyes and dry mouth, and skin foam in the form of erythema nodosum. Erythema nodosum is very important for the diagnosis of sarcoidosis. Silicosis is another term which can cause eggshell calcification, and there is a history of TB also. There is another MCQ which is about the pneumothorax. Avoid air travel for 3 months in the case of pneumothorax. Lofgren syndrome is a continuity of sarcoidosis. If sarcoidosis present as arthritis, erythema nodosum, and bilateral hilar lymphadenopathy, it is basically Lofgren syndrome. There was another MCQ regarding the causes of central cyanosis. So central cyanosis causes can be remembered as mnemonic DRAP. DRAP is basically decreased ventilation right to left shunt, acute pulmonary edema, polycythemia. So the question was asked which of the following is not a cause of the central cyanosis, and the wrong option was left to right shunt. So it is important to remember that the right to left cardiac shunt is causing central cyanosis, not left to right shunt. Pneumothorax is very important for the MCQ point of view. For pneumothorax, you have to remember, first of all, you have to categorize whether it is traumatic pneumothorax, primary pneumothorax, or secondary pneumothorax. If there is history of injury or trauma, then it is straightforward traumatic pneumothorax. If traumatic pneumothorax is less than 15%, it can be observed. The patient can be sent home with a 24-hour monitoring. Then if it is greater than 15% or symptomatic, then you have to put the chest drain into that patient. If the patient is presenting with the primary pneumothorax, and primary pneumothorax are basically the young patient, tall patient, without any history of smoking, without any history of any lung disease. If the patient is having primary pneumothorax and less than 15%, then observation is the right option. And if it is greater than 13%, then needle thoracoaspiration in the second intercostal space is done. If patient improves, it can be discharged. If patient doesn't improve, then chest drain has to be passed. If secondary pneumothorax, like in old age, and the patient is having smoking and COPD or asthma patient, if it is less than 15%, needle aspiration is the answer. If it is greater than 15%, chest drain is the right answer. In secondary pneumothorax, you cannot observe the patient. You have to deal the patient with the important management. Then another important concept is this. This is basically allergic bronchopulmonary aspergillosis. If there is a history of recurrent attacks of asthma, and in the scenario he is given the eosinophilia and raised IgE levels and central bronchiectasis is mentioned, then this is a clear-cut scenario about the allergic bronchopulmonary aspergillosis. So this was all about the respiratory important points for the MCQ. Hope this is beneficial for you guys.